रेफरल कोड लगाया, कूपन कोड लगाया, कार्ड नंबर लगाया, उसके
Yeah, we are live now. We'll start shortly in another 2 minutes. We'll wait for the audience to join.
fresh to home.
Hello. We have around 50 people who have already joined. We'll start off at sharp 12. Yeah, we are ready to start. Hi all. As you all know, today is World AIDS Day, and the theme for this year is End Inequalities and End AIDS, with an emphasis on reaching out to people who have been left behind. As you all are aware, the management of AIDS have come a long way from 1990s. With significant changes in the management principles itself. So in this session, we will be dwelling into the basic concepts in management of HIV. I'm sure you would have listened to the previous sessions, that is the lecture and also the case presentations. And as we have told, there will be a post just after the CME, which will be shared in the community tab. And you have to answer that to get a completion certificate. Again, as with our usual panel discussions, the format is as we usually follow, that is pre-planned questions for the initial 50 to 55 minutes, followed by a few audience questions, which you can share in the chat box. And that'll be it. Okay, so for today's session, I have with me Dr. Anil Kumar, sir, who is the head of the Department of Microbiology at Amrita Institute of Medical Sciences. Welcome, sir. Girish Kumar, sir, who is head of the Department of Emergency Medicine. Welcome, sir. And Dr. Deepu, who is an associate professor in the Division of Infectious Diseases at the hospital. Welcome, Deepu. So we will start off with some certain basic principles and then move on to certain controversial or rather not very clear kind of areas in the management. I'll start off with Girish, sir. So HIV and AIDS are two terms which people use interchangeably. So if you can tell us what's the difference between two, and also a quick note on the modes of transmission of the same.
HIV is one virus, human immunodeficiency virus. That virus reduces our immunity. It reduces the number of CD4 count or quality of the CD4 cells. Mm-hmm. Ultimately, when it drops from a normal level, that is 500 to 1200, it drops slowly. In a year, it may drop around 100 cells per year. Okay. So ultimately, it will reach a level 200, less than 200 level. Mm-hmm. At that level, the person who is having that HIV virus is prone for all types of opportunistic infection. Opportunistic infections are the infections which is already there in our body, like some fungal infection, some unusual infection which routinely we don't see. All these things can come up during that period. That time the patient develops opportunistic infection or opportunistic types of cancers, we call it as acquired immunodeficiency syndrome. There are some other immunodeficiencies like the congenital immunodeficiency syndrome, like IgG deficiency, IgM deficiency, Ig deficiency. They are a congenital type of deficiency. Here, patient is having a viral infection which reduces the immunity, and patient develops all opportunistic infections. That time we can call the patient is having AIDS, acquired immunodeficiency syndrome. So that is the main difference between HIV infection and AIDS. The immunodeficiencies can be in various other diseases also, but here it is acquired due to a virus, that is HIV virus. That is the main difference between an infection and the disease.
Okay. And the modes of transmission, if you can.
Modes of transmission, one of the most common modes of transmission is unprotected sexual intercourse, whether it is like a male to male or male to female, whatever may be the sexual intercourse. There is a chance of spreading infection from a person to other person. That is unprotected sexual intercourse. In that, again, repeated sexual intercourses with unprotected, like condom is not used, then that is the most common cause. But if you are taking the percentage of transmission, it is very, very less. Only 1% transmission can occur. Out of 100 encounters, only 1% can get the disease. So the gravity is not that high to transmit the virus, but the number of encounters are very, very large. That's why 75% of the infections are due to this one. But other common conditions nowadays, intravenous drug abuse is increasing. Sharing of needle is one of the most common. For us, like healthcare professionals, it is mainly accidental needle prick injuries, splashing of blood or other this one body to fluids, our eyes, body fluids to our eyes or oral cavity, wherever it is. Then mother to child transmission, nowadays it is very, very rare. So these are the common cause of transmission.
Okay, sir. Next
I would
question.
like to add one thing.
Yes, sir.
All as sir has differentiated between AIDS and HIV. All AIDS patients are HIV positive, but all HIV positive patients are not AIDS. So that is the basic difference between them.
Yes, sir. Right, sir. So next question, I have clubbed two questions into one. That is, what is HIV 1 and HIV 2? And also we hear of a lot of tests like serology, ELISA, PCR, Western blot. If you can just put in some clarity on when to use what.
Okay. Now, HIV, similar to COVID, has a zoonotic origin. And we definitely know where it came from. It is simian immunodeficiency virus that is jumped from chimpanzees and Suti mangabeys. So there are two HIV viruses, HIV 1 and HIV 2. Though the disease was first discovered in 1981 due to pneumocystis carinii outbreak in homosexuals, the virus was identified late in 83 and 84. And virus first was identified was HIV 1 and second was HIV 2. At 1986 it was discovered. So HIV 1 and HIV 2 are the two different HIV viruses. Having said that, HIV 2 is not similar to HIV 1, only 40% similarity. So HIV 2 originated from a different monkey, that is Suti mangabeys in West Africa. And HIV 1 came from chimpanzees. And HIV 1 is the most commonly seen all over the world. Most pandemic prone is HIV 1. And HIV 2 is only seen in West African nations. It's not that I haven't seen in my lab. I have seen occasional cases of HIV 2 also. And now the difference between both the viruses, HIV 1 is the most infectious, most virulent, most transmissible, and sexual intercourse transmission is very high in case of HIV 1 when compared to HIV 2. So HIV 2 is not highly transmissible, not that virulent, and the genetic mutation is very high in HIV 1. So you have a lot of mutants in case of HIV 1. So genetic variability is not that great in case of HIV 2. So HIV 2 we have only 5 subtypes. HIV 1 we have at least 10 subtypes. After the major or newer and outliers, we have 10 subtypes. So we have plenty of genetic variability in HIV 2. HIV 1. HIV 2, if a person is having HIV 2, only 20 or 25% will ultimately develop AIDS. Rest of them go to a long-term non-progressive state. That is, they don't develop AIDS, but they can maintain a good CD4 count and low viral load. So HIV 2 is less likely to develop AIDS, while HIV 1, most of them will develop AIDS by 8 to 10 years if they are not given treatment. So Generally speaking, HIV-1 is more dangerous, more transmissible, but HIV-2 is less dangerous, less transmissible, less chance of getting AIDS. But all the research is focused on HIV-1.
Okay.
So if you get a good treatment, it's HIV-1. If you get a vaccine, it's going to be HIV-1, not HIV-2. So that is the only problem.
Okay, got it. So second part of the question on the various tests available.
Test. That's very important because everybody is apprehensive to know when we can test, and if, especially a healthcare worker coming with a needle stick injury is very apprehensive to know as soon as possible.
Yeah.
So broadly speaking, if you have a molecular assay, that is a viral load assay or a nucleic acid testing, that NAT testing done in blood banks. If you want to do that, that's the best assay, but the window period is after 12 days.
Okay.
You have to wait for at least 12 to 15 days. 12 days. Okay. After 12 days, only order an HIV viral load.
After 12 days of an encounter.
After 12 days of an encounter or a needle stick injury, if you want to look for AIDS, the HIV, then go for a viral load or a nucleic acid based testing.
Okay.
On the 16th day, you can do a P24 assay. P24 antigen will come into circulation. Now, having said that, P24 assay is there in most of the 4th generation ELISA. We use a 4th generation ELISA. So if we run our preoperative serology is a 4th generation ELISA. A chemiluminescence is very sensitive.
Okay.
So on the 16th day, if the patient sends a 4th generation ELISA, we should be able to pick it up.
Okay.
So if you want it early,
Okay.
and by 30th day, all our 4th generation ELISA will come positive. All our HIV ELISAs based on antibodies will come positive.
Okay.
So 12 days, you do a molecular test after 12 days. After 16 days, do a P24 assay or a 4th generation HIV ELISA. Make sure it is a 4th generation HIV ELISA because that only picks up a P24 antigen. And by 30th day or after 30th day, you go for any antibody assay, it will pick it up. Having said that, after 30th day, you have the antibody levels in a robust manner. So order a Western blot only after 30 days. Only then there is a likelihood of picking up different antibodies in case of HIV. So Western blot is a confirmatory test. Only after you get at least 2 of the test positive, go for Western blot.
Okay.
With so many excellent assays now available, we don't need a Western blot in the first place. When our pre-op serology says the value of 1,000, 2,000, that means it's surely a case of HIV. You have to do another supplementary assay to confirm that finding and finish it off there. It's noted that it's HIV positive. Very rarely nowadays people go for a Western blot rather than put your money on a viral load and find out how much the viral load is. Because Western blot is an expensive test.
Okay. Just extending it, can there be false positives in serologies? Yeah.
False positive is always there. Now, if you have a pre-op serology which gives a value of between 1 to 10, anything above 1 is positive.
Yeah.
1 to 10, I am very skeptical that it may be a false positive thing.
Okay.
Pre-op serology, because it's a very sensitive test. It will pick up even false positive ones.
Okay.
There you have to do another assay
Okay.
to confirm whether it's positive or not.
Sure.
So there we have, and causes of false positive is autoantibodies, pregnancy, many other things.
Okay.
But false negative, if you go into the window period. If you order the ELISA
True.
before the
Too early,
16th day in a 4th generation, it's false negative.
Okay.
Before the 30th day, in case of any ELISA, because most of the people have got 3rd generation ELISA, only picks up antibodies, not antigen.
Okay.
There, don't order that before 30th day of exposure.
Okay. I'm sure that would have given a lot of insights into when to do what tests. Next question, I'll move to Dr. Deepu. I'll give the mic. Okay. Deepu, what are the common clinical features of HIV? And is there any early features, and can we classify it into early and late features? Yeah.
Yeah, that's a very basic question which we all should be very familiar with.
Yeah.
So definitely at the time of exposure there is an acute phase because at the end of the day it is a viral illness. So just like any other viral illness, it also will present like a flu-like illness. Only thing is that it need not develop into a flu-like illness in every patient, but at least in 40 to 50% of the patients, the HIV can develop a flu-like illness with sore throat, mild cough, myalgia, arthralgia, rashes. So this is the common presentation, at least seen in about half of the patients, and most of the time it will subside in a week's time. But in a small proportion of patients, say 5% of the patients, the symptoms can last for up till a period of month. So that is the acute phase of HIV infection, and that is how the patient, most of the time patients will not present to you at this phase, but sometimes they can present if you are able to elicit a definite exposure history. Then you can consider thinking in this line, and definitely, as Anil sir told, we can utilize the test accordingly. The second phase is more like a silent phase or a clinically quiescent phase, in which the virus is there, the virus is actively multiplying. So we know that virus, Grisa told, the virus is infecting the CD4 cells. It is an RNA, reverse transcriptase, and then it will become a DNA, will get integrated into the genome of the CD4 cell, and slowly from there, using the machinery of our gene, it will start getting multiplied, and in the process it destroys the CD4 cells. So this is what is happening in that quiescent phase. So it is clinically quiescent, but actually the viral multiplication is ongoing during that phase. And as the viral multiplication goes on, the CD4 cell starts dropping, and at a particular point when the CD4 cell starts dropping, we start getting infection. The HIV patient starts getting infection. Before that, he is prone for infection just like any other person, but when the CD4 cells drops below a critical point of less than 500, and in that period of I'm not telling the absolute value, but when it starts falling, the chance of infection is going to be high. So that is the time where the patient is going to come to you again after the initial acute febrile phase. So, and at that point of time, most of them may not be even aware that they have an HIV kind of infection. So at that point of time, initially when the CD4 counts drop below a critical point of less than 500, they can have more of like multiple cutaneous infections or sinus, recurrent sinus infections, recurrent ear infections, even herpes infections, dermatitis. So it will be more concentrated towards the external aspect of the body. But when the CD4 counts further drops further, then they will have more typical features of AIDS defining infection, including the esophageal candidiasis, PUO, multiple lymphadenopathy, hepatitis. And once it again drops to the critical value of less than 200 or below, then all the AIDS defining illness will start coming in. As I told you, AIDS defining malignancies, then cryptococcosis, CMV, toxoplasma, encephalitis, meningitis. So all those infections will start pitching in, and the patient can present with those kind of complications to us. So at that phase, we will call it as acquired immunodeficiency syndrome, because by the time all the CD4 cells are lost due to the viral multiplication. So the acute febrile phase, second is the clinically quiescent chronic infective phase, and third is the AIDS phase. So this is how the classification will be.
Okay. Thanks, Deepu. Girish sir, can we always define a conversion time for a patient to be exposed and then moving into AIDS?
It is difficult to tell the exact timing, but as Deepu and Sir told, it is average timing is 8 years. Like somebody is getting an HIV infection. From that CD4, normally if you test somebody's CD4 count, it will be somewhere around 800. Because the range is given from 500 to 1200, but normal person can have a CD4 count somewhere around 800. Every year CD4 count drops by 100 cells per year. Like if you just calculate, it takes average 6 to 7 years to drop the CD4 count less than 200. That's the time your patient is going to get AIDS. So till then, patient will be absolutely normal. There will not be any clinical finding. Like you can develop other infections like any other person, but these opportunistic infections come in that much year it will take. But there are some patients, they are long-term non-progressors. Their CD4 will never fall. They are infected with virus. They can infect the virus to other person, but they are not developing the disease due to some reason. So they have the virus, but their CD4 counts are not dropping. This is called as long-term non-progressors. That subset of patients are there. Even then, average timing is 5 to 7 years. So by 8th year, normally they develop symptoms of AIDS. So that's a time span from HIV infection to AIDS, normally.
The catch is that no treatment.
If they are not taking treatment.
If it's treatment, then it's unlikely to happen.
If they're taking treatment means it will not happen. That AIDS will...
Even long-term non-progressor is defined as no treatment.
No treatment. Both are without treatment.
ERT, and he is continuing to have a good CD4 count.
Yes.
And sir, just in continuation to that, what's the real role of viral load testing
The sir has already told that you have definition of weights contains CD4 level.
Yeah.
The definition of weight says less than 200 CD4 cells
Okay.
or having an AIDS defining illness.
Yeah.
If the patient is having cryptococcosis or cryptosporidiosis or a mycobacterium infection, then it's AIDS defining illness and it fits the criteria. So CD4 is the best test to evaluate the prognosis as well as the disability.
Yeah.
So a CD4 of less than 200 was given the cutoff. The clinical criteria also A, B, and C, as Dr. Deepu has already told, that asymptomatic and the chronic phase and the AIDS defining state. That also is divided into according to the CD4 level.
Yeah.
Anything below 1, 2, 3, less than 200 is 3. 2 to 200 to 500 is 2 and 1 is more than 500.
Okay.
So A1, A2, A3, B1, B2, B3 you can. So you can stratify the patient according to the CD4 level. So
Yes.
CD4 is very, very important. It tells you the disability of the patient.
Okay.
The reason why the patient is falling sick or getting opportunistic infection, dying, is because of the CD4 levels. Because he has gone down less than 200 and he is prone to any infection now.
Yeah.
So that is the reason why CD4 should be regularly done. The moment you get an HIV positive result of a patient, order a CD4 cell, see the levels. Then repeat it every 3 to 6 months. Give him ART. If he is stable, you can go for 6 to 12 months once you have to do a CD4 cell.
Okay.
So even if the patient is having less than 50 CD4 level, 45% chances that he will die within 1 year without ART. So that is the level of importance of a CD4 level.
Okay.
And if he is having 100 CD4 level, more likelihood that he will get an iris when you start a ART.
Yeah.
So that all we can determine using a CD4 level. So CD4 level is the best thing that you should be doing to follow up a patient to know the disability.
Okay.
US gives disability benefit to people who are less than 50.
Okay.
So if you're less than 50, you get disability benefit from the government, support from the government, medicines, everything. Moment you are above 50, you lose that.
Okay.
So that's the importance of CD4 level in HIV.
Okay. And viral load?
Viral load is a good thing.
Yeah.
Viral load we should be doing because once you should be doing the moment he is diagnosed.
Yeah.
Why it confirms the disease and then you also know the level of the virus. And then during follow-up, viral load is expensive, 4,000 rupees. So expensive than CD4.
Yeah.
If you give me an option to do which one, so I will say order a CD4 to the patient. Yeah, that gives you a better level of the disability the patient is suffering. Viral load will fluctuate. There is no linearity between CD4 and HIV viral load. So it doesn't tell you no correlation.
Yeah.
So may have a high viral load in spite of having a good CD4.
Okay.
And viral load tells you the disease, and for drug resistance you can do viral load.
Okay.
The patient is on ERT for 1 year and still the viral load is not going down, then you can do a genotyping for drug resistance.
Okay.
So viral load doesn't tell you disability of the patient.
Yeah.
So viral load should be done, occasionally should be done. If you're suspecting resistance, you should be done. You can do a genotyping. But otherwise, viral load is not that great when you compare to CD4.
Okay.
So if you give a preference, a cost-effective way to monitor a patient is go for CD4 level.
It will have a role if you are going for a resistance regime.
Only then you think of viral load and see whether viral load is very high or not.
Okay, sir. So regarding the investigations, last question to Deepu. Deepu, we already mentioned about the secondary infections in HIV patients. So if you can quickly outline some investigations which can use as a screen to find out secondary infections, it will be helpful.
Yeah. So basically, in order to decide that, we need to have an idea when a particular patient is going to get what kind of infection. So again, as SARS told, we need to have an idea about the CD4 count, and depending upon the CD4 count, we can actually guess what is the kind of infection the patient is going to have. Because CD4, as we told, it is a once there is CD4 cytopenia, then the patient are prone to various kind of infection. So at more than 500, they are just prone to all infections like us only, like the pneumococcus, the H influenza B, the Staph aureus. So there is no need to do any specific investigation. If they are getting sinusitis or respiratory infection, we have to just do the routine sputum FB, sputum cultures. We can just do the routine syndrome-based diagnostic workup. The exact test maybe NSR can help. Then second, if they are coming to less than 500, that is the time the chance of tuberculosis is kind of very high in this group of individuals. So if a patient with CD4 count of less than 500 is coming to you, or if a patient is coming to you with respiratory symptom, and then the X-ray is showing some kind of features suggestive of a lobar pneumonia, then at that point of time you have to start suspecting tuberculosis. So this you have to little proactively suspect. So other than that, with a CD4 count of between 500 to 200, you are more prone to certain viral breakthrough infections in the form of cutaneous infections, like herpes HSV, or even herpes zoster infections, shingles. So that is you may not needing a diagnostic test, but you need to have that kind of clinical acumen to diagnose that. But tuberculosis you have to consider, and all pneumonia case you have to actively rule out tuberculosis. And the between the 500 to 200 range, the diseases like NHL are also will take precedence. When it falls below 200, that is the time you will get more yeast kind of infections, cryptococcuses, then even the GI infections like isospora, cryptosporidium parvum infection. So pneumocystis carinii, but pneumocystis is below, less than 50. So less than 200, you will get these kind of infections. So in a patient who is less than 200, but maybe more than 100 or more than 50, that group of infection, when they present, you have to suspect more of yeast infections. And for if a patient is presenting to you with diarrhea, then that time you have to think of this cryptosporidium parvum, isospora bejeli. So these infections you need to think of. And also sometimes the salmonella enteritis, it could be chronic in this group of individuals. So depending upon again the syndrome, if it is a GA syndrome, then stool routine, stool cultures you have to order, and this is what in your mind at that point of time. And then if it is a CNS infections, of course cryptococcus is a problem, and if it is a lung infection other than tuberculosis, cryptococcal pneumonias are also a problem. So cryptococcus you need to specifically do in this kind of meningitis. And if the patient is presenting with CNS lesions at this range of more than 50, more than 100 to less than 200, then toxoplasma is another thing you have to keep in mind. So IgM toxoplasma. Once it is less than 50, that is the time you will start thinking of PCP pneumonia. And even the yeast infections will transfer to mold infections, like invasive aspergillosis. And like always there is a possibility of invasive aspergillosis, but this just disproportionately goes up once it falls below CD4 counts is below 50. And also the mycobacterium intracellular, avium intracellular, other atypical mycobacteria, all these things will cause a disseminated disease during this period. So that clarity also you need to have in mind. Whether any special investigation to be done to detect this investigation, or the syndrome based, I think I would rather
there will be patient specific kind of
patient specific and syndrome based. These are the infections you need to keep in mind. And depending upon that, after discussing with your microbiologist, you can order the specific tests.
Okay, clear. I'm seeing some questions regarding the post test. As I had told in the beginning, the test will be posted in the community tab soon after this session. And it's going to be an MCQ, and anybody who has seen attended the CME from the beginning, it'll be easy for you to attend, and there will be a minimum cutoff for you to get the certificate. So we'll move on to the next question to Girish sir. So coming on to the treatment part, what is ART, and when do you start ART?
ART is antiretroviral therapy. We know that virus is entering to our CD4 count, and there are multiple phases for that entrance and getting to the genome, transferring the genome, taking that genome and acting, killing the CD4 count. There are multiple phases. All these drugs act on specific levels. So what we should understand is ART is not a cure. It only suppresses the viral replication. This virus can go and hide somewhere in our body. Without these drugs cannot act there. So it's not a complete cure. It's only it can control the disease. So there are multiple drugs. That's why we call it as highly active antiretroviral therapy. That means it's a combination drug. Like TB we give combination, or some other hypertension we give combination, diabetes we give combinations. Combinations are always better to control the viral growth, and it is better for not to develop resistance. So we have multiple groups like NRTIs are there, NNRTIs are there, protease inhibitors are there, insta-based regimes are there. All these things we have explained in detail in our previous classes. So what happens is when we are giving only single drug, the virus can develop resistance against this drug. So that drug will become useless. So what happened is during the process of evaluation of HIV treatment, they have taken 2 drugs from the first group, that NRTA, 2 drugs, and one drug from either NNRTA or protease inhibitor or Insta-based regime.
Okay.
That is ART. So
Okay.
3 drugs minimum we have to give.
Okay.
2 from the first group, 1 from the second, third,
third, yeah.
or fourth group.
Okay.
But now the most common, most preferred regime is dolutegravir based regime. So we give 50 milligram dolutegravir with tenofovir lamivudine or tenofovir emtricitabine. This is the most widely, most commonly used regime.
Okay.
There are multiple other regimes. Depending on the patient scenario, we may have to change some of the drugs. But most commonly used drug is tenofovir lamivudine with dolutegravir.
Okay.
So we call it as highly active antiretroviral therapy.
Okay.
Next question: when to start?
Yeah.
So previous guidelines I have to tell now. Because previously it was when the CD4 count drops less than 200, you have to start the treatment. The old guideline was like that.
Yeah.
Then after that, after some time, they told CD4 less than 500. Now the newer guidelines is as soon as you make a diagnosis of HIV, we have to start ART.
Okay.
Only one type of exception is if you have an active opportunistic infection, like they were told so many opportunistic infection. If you have an active opportunistic infection, treat that first. Once the patient is stabilized, go for the ART.
Okay.
Otherwise,
Okay.
what happens is Dr. Anil has already told, like immune reconstitution syndrome.
Yeah.
So if you don't treat the opportunistic infection and start ART first, the patient's immunity starts improving, and that immunity will act against this opportunistic infection. Patient will immediately deteriorate. That is called as immune reconstitution inflammatory syndrome. So in a normal person, as soon as you make a diagnosis, start ART. We will not wait for CD4 count. We will not wait for viral load, nothing. HIV positive, you confirm the diagnosis with whatever investigation, then start ART. Don't wait for any other investigations.
Okay. Okay. I think that very much clear. So you have to start treatment if there is no obvious signs of opportunistic infection as soon as you detect it.
But there's a catch that he has to take it lifelong.
Yeah. Okay.
So that counseling is required.
Yes, sir.
We have to counsel properly that the person should take every day. Even if the patient miss one day ART, he'll develop resistance at least 5 to 7%.
Okay.
So 1 or 2 days if he miss, then slowly the drug will become resistant. So that disadvantage is there.
Okay.
You should be mentally prepared to take the tablet lifelong.
So just in continuation, sir. So you told about 3 medications. So does it come as a single tablet or is it all?
Now it is as single tablet.
Okay.
Previously it was pill burden was very high.
Yeah.
Previously, nowadays we are getting it as a single pill.
A combination.
So, that's the advantage.
Okay. Okay, sir. And so just, I think we touched upon this point already, but just to re-emphasize, what test do you follow to follow up these patients, and is there any chance for serology to become negative once treatment is started? And yeah, that's it.
We have touched all these things. Once you get a diagnosis of HIV, antibodies are always there in the system. So there's no point in doing another antibody any point of time. The only thing you need to do is a CD4 cell and a viral load. Ideally, both should be done together. But if there is cost constraint, not availability, then CD4 is the better option to go to follow the patient. And occasional viral load needs to be done. So there is no reason to believe that HIV will become negative at any point of time in that patient's life. So that is clear that you have to do only these 2 tests. Following up is CD4 viral load.
Yes.
No antibodies anymore.
Okay. Okay. Girish sir, next question. I think we often see TB and HIV coming together. So you already told about what to treat first, but if TB is there any change in management strategies or?
No, there are multiple guidelines. Like British HIV Society has got their own guidelines. That's one of the standard guidelines. But in India, these things are like not very practical. What we have to see clinically, we have to check the patient. All these guidelines are depending on the CD4 count, viral load, all these things. But in India, we have to see the patients. Like a person who is having normal CD4 count, TB is like any other normal person.
Okay.
Yeah, you can start both TB treatment and ART together.
Okay.
Only thing, most of these patients we start anti-tubercular drug first.
Okay.
See any drug-related problem, like patient can develop hepatitis or something. And once the patient is stabilized with that drug, we are seeing for the drug related side effects. Once the patient is stabilized, we can immediately start ART. But somebody is having a very low CD4 count. If we have a tuberculosis, treat the tuberculosis first. Don't wait for the last part of the tuberculosis. To initially stabilize the patient, at least 2 to 3 weeks you continue the ATT. And once the patients, like normally in any person, the TB subsiding starts after 2 weeks of the normal regime, if that's not a resistant case.
Yeah.
After starting 2 weeks, they'll become like better. Their appetite improves, fever comes down. So that time you can start ART.
Okay.
Otherwise, what happens if you are starting ART and ATT together, or ART starts first? This is the most common mistake done by most of the doctors. So they diagnose HIV and TB. They think that HIV will kill the person. HIV will never kill a person.
Okay.
It slowly deteriorates the immunity,
Yeah.
and the opportunistic infections are going to kill.
Okay.
So they start ART first,
Yeah.
antiretroviral therapy first. So the patient's immunity increases drastically. Like Dr. Anil told, from 50 it may come back to like 100 or 200. So that time the body immune system will try to act against this tuberculosis. They have IRIS, that is immune inflammatory reconstitution syndrome. So they actually deteriorates. To avoid that, start ATT first.
Okay.
Look for the side effects.
Okay.
If the patient improves after 2 weeks, we can start ATT. Sorry, ART.
Yeah.
But if you see the guidelines, they have each CD4 count, timings are given, like 2 weeks, 2 months, like that.
Okay.
But it is not very practical, because what we have to understand is CD4 drop is not only quantitative. It is already, I have already told, it is quantitative and qualitative. The quality of the CD4 also drops. So clinical features are very, very important when we are managing this type of patient. We cannot go according to the CD4 count what is given in textbooks. We have to see the patient.
Okay.
The patient clinically improves with TB, you can definitely start ART.
Okay.
So that is the easiest thing to be done in our country.
Okay. Okay. Next question to Deepu. Deepu, another place where we probably need to know a bit more about HIV management will be the specific group of pregnancies. So, is there any treatment modifications, and also is there any way to prevent vertical transmission?
Yeah, so definitely as far as the treatment in pregnant women is concerned, the main aim is, two aims there. One, to ensure that the HIV in that pregnant lady is kind of controlled, just for her health.
Yeah.
And second, of course, the baby's health. We don't want the baby to be positive.
Okay.
In early 2000s, the chance was 5 to 10% of babies born to pregnant mothers were positive.
Okay.
But now, as are told, there are newer regimens, because of which the chance is almost negligible. So second thing is that we need to, as soon as we diagnose the HIV in a pregnant woman, and if she is not already on treatment, we have to start the treatment. There is no questions asked. So that is one thing.
Okay. Irrespective of the period of pregnancy.
Irrespective of the period of pregnancy.
Okay.
Second thing is that during the time of delivery, we have to opt for cesarean delivery. That will minimize the chance of baby getting infected. Third, once the child is out, within 6 to 12 hours, we have to start the post-exposure prophylaxis for child as well. And the next point is breastfeeding. Breastfeeding, if possible, we should, of course, in countries like United States, they are not at all in favor of breastfeeding. So there is no breastfeeding. But in countries like ours, depending upon the situation, we have to decide which is going to kill the baby, if whether it is going to HIV, or if you are not breastfeeding, sometimes if the child is malnourished, and if the kid is from a poor background, then it may not be practical. So in that kind of situation, we have to continue the ART for the kid, and then we have to allow breastfeeding.
Okay.
So these are the things which we need to keep in mind. Right?
Okay. That's interesting. Next question to Girish sir. Another area will be regarding the post-exposure prophylaxis, both in needle stick and sexual contact. So when should we start prophylactic drugs, and what is the preferred regime?
Okay. So whenever we get as healthcare professionals, we get a needle prick or whatever maybe injury during operating or giving IV line, whatever it is. What we should understand is a blunt trauma, like you're getting a needle prick injury from a sharp needle without bore. There is no blood in that. So the risk is very, very minimal. But whereas when you are putting an IV line, that contains that IV cannula contains some amount of patient's blood. If you are getting a needle prick from that, the risk is higher. But we cannot predict, it's normally given 0.03% from needle prick. But for somebody is getting an infection, it is 100%. So we cannot tell the person that it is only 0.03%. If you are getting a needle prick, suppose unfortunately you developed the infection, for you it is 100%. So we cannot take it very lightly. So whatever may be the needle prick injury, what you get, what we have to do is, first of all, you have to do your your HIV ELISA status first itself.
Okay. To know whether it's already there or not.
Because we are working in high risk areas, we can develop any type of infection. So first of all, document that we are not infected with HIV virus.
Okay.
Once we know that the person is positive, sometimes what in emergency room, patient will be new patient. So we have to take a sample from the patient also. If it's a non-patient, it's okay.
Yeah.
Otherwise, take a sample from the patient, take a sample from the healthcare professional for HIV ELISA testing.
Okay.
Then as soon as possible, we have to start at least 2 drug regime and if possible 3 drug regime. The same drug, tenofovir, emtricitabine, dolutegravir.
Okay.
So it is easy to remember all these things, because if you read textbooks, there are multiple regimes are given. If you read standard medicine textbook, there are a lot of drugs they mix and match.
Yeah.
So many regimes are there. So actually it is not required. You remember 1 or 2 regimes, so that will be easy. So tenofovir, lamivudine, dolutegravir. Same drug is given for treatment. Same drug is given for prophylaxis.
Okay.
As soon as possible, start the drug. Don't wait for anybody, because it's our life. You start the drug. There is no major side effect for all these drugs. And wait for 30 days. Stop it. If there is no problem, after 30 days you can stop it.
Okay.
But during that 30 days, you will be having mental trauma and a lot of tension will be there. So ideally, this person should be counseled.
Okay.
Otherwise, they'll have that 30 days is very important time. So give counseling. After 15 days, like Anil sir told, you can go for HIV RNA PCR if you want to make a diagnosis, or after 30 days, go for ELISA. If you are opting for ELISA, again after 6 months, again reconfirm it that there is no infection. Okay. But after 30 days, we can stop the medicine. There is no need to continue the medicine after 30 days.
Okay.
But after 15 days, if you are going for HIV RNA PCR, if it is negative, still you have to continue the drug. Then probably after 30 days you do 1 more ELISA. Then no need to go for further testing. Okay. But only ELISA means after 6 months doing 1 more test is required. Okay. There is no major side effects for this drug regime. Yeah. Previously, when we were using sidovudine and all, we used to see the blood counts. Nowadays, it is not required.
Okay. Okay.
So there are anecdotal reports where they say that when a PEP is given to a patient, the seroconversion is delayed. So when in one case they had a publication that they said that after 12 months they did a ELISA, it came positive. Oh. So in such cases, it's better to be on the safer side to do a ELISA after 1 year. As said, after 30 days it's not negative, you leave it there. And after 1 year, for a caution, you can do a ELISA to just rule out, because PEP may delay the seroconversion, because a robust PEP, Dr. Sir has told that 3 drug regimen is a very robust regime, so that may suppress it very well.
That is because previously what happened is many patients were on these drugs like ART, and the virus may be resistant to that drug. The same drug we were using for post-exposure prophylaxis also. Okay. So if the patient is already failed, then we also will fail. So that time these things were happening, but nowadays is a recent drug like dolutegravir is a recent drug. Okay. Resistance is not well documented. So time being we are on safer side. But again, like sir told, after sometimes this drug also will show some resistance. Patient will have dolutegravir resistance. If you are taking that dolutegravir, we can also fail. So it is always better to avoid needle pricks. So prevention is better than cure. That we should remember. Okay, all patients come to ER should be treated as an infective patient.
Okay. Next question to Anil sir. Sir, there has been a lot of interest regarding HIV vaccine. Even with COVID, we were able to come out with a vaccine so fast. So what is the limiting factor in bringing out a successful vaccine?
Your statement that for COVID we were able to get the vaccine very fast, we have to be indebted to HIV.
Yeah, okay.
Because for the last 10, 15, 20 years, they have been doing intensive research in HIV. Okay. Whatever vaccine you are saying about COVID, everything is there in HIV. Your Covishield vaccine containing the chimpanzee virus. There are 4 vaccines based on chimpanzee virus which is already on trial for HIV. Just because we had that model available, we just tweaked it. and made it for COVID because it was successful. So there chimpanzee virus, then adenovirus, that adenovirus vaccine. All of them are therein. Even monoclonal antibodies. HIV, there is a monoclonal antibody regimen where you can give a potent monoclonal antibody which has got broad neutralizing activity along with your antivirals to prevent, suppress the viral load. And they are also, they can also be used for post-exposure prophylaxis like we give for hepatitis B. So these things are already there being tried very well in HIV, but unfortunately we don't have much of a success. The reason being that this virus is notorious for mutation. It is far more mutable than the influenza virus or than the COVID that we see. So 65 times more mutations you see because the reverse transcriptase is very error prone. The reverse transcriptase gene is very error prone. So every time it multiplies, it causes errors and there are so multiple genetic variants are there. There are 10 subtypes for HIV. So if you want to create a vaccine, you have to have that amount of neutralizing antibody that will neutralize all these mutants, all these variants. So that is the biggest challenge. Second biggest challenge is we don't have an animal model, the human animal model. HIV does not infect the chimpanzees. SIV does not infect humans. So if you want to do a HIV vaccine trial, you can't do on chimps or animals. They don't get infected in the first place.
Okay.
So what we do is we work on chimpanzees with simian immunodeficiency virus with the similar vaccine to know whether it's effective or not. Then we extrapolate it to ours. So we have to have humanized models, small animal models also humanized, to know whether it will actually work. So the first few vaccines were first tested in chimpanzees using simian immunodeficiency virus.
Oh.
That's why it failed.
Okay.
So we never knew how it will work in human beings.
Okay.
So that is the second biggest challenge, that we don't have an animal model there.
Okay.
And then this inducing an induced CD4 antibody, the CD4 response and humoral cells in a robust manner is also very difficult in case of HIV because of these mutants. So that is also not being achieved. Again, we have the virus has got a sugary layer on the surface. The sugary layer covers the antigens, the spikes on it very cleverly. So the antibodies are not able to neutralize it. So there it also has got an evasion.
Yeah.
So these are the reasons why we are very challenged to get they have vaccines, but they were not working. At the most, 30% efficacy was seen in one of the vaccines, not beyond that. So it's very difficult to get a very complete vaccine to neutralize all the mutants, all the variants that we see every day. So that's the reason we are not able to get the vaccine. But all these were done for HIV. They have just been copied for COVID and it's working very well.
Okay. Okay. That's interesting, sir. Next question to Deepu. Deepu, is there any relation between COVID and HIV in general? And also, can an HIV patient or should a HIV patient take all the vaccines which is available?
Yeah, just as an additional to the point which Sir already told, just to give you the perspective of the HIV vaccine from the COVID point of view. We know that there are 4 variants: alpha, beta, delta, theta, delta, and now Omicron has come. And the moment Omicron has come, what is the question which the scientific body is asking? Whether the vaccines are effective, whether the classical vaccine which we developed will be effective for the new variant, whether the monoclonal antibody will be effective, even whether the drugs which we are boasting about, like remdesivir and recently molnupiravir, whether it is going to be effective. So just with 4 mutations, we are asking these questions, and we are really worried. We are thinking that it may not. Definitely, when the effectiveness of Covishield was 60%, when it came to Delta, it just dropped to 40%. And with Omicron, it is highly likely that it is going to drop further. But definitely, it could still prevent the severity of the disease. That is another thing altogether. But then, just to give the understanding which Anil sir has told, with just 4 mutation, we are asking about these questions. And with the HIV, with all the mutations going on, it is. And now coming to the other part of the question, that is
HIV and COVID.
HIV and COVID and other vaccinations. So, being a person having HIV is not increasing the risk of COVID transmissibility. Definitely, the COVID transmission risk is just like any other person. But if the patient is on the immunodeficiency side, then he is a high risk candidate for getting severe COVID infection. Okay. Then regarding the vaccination broadly we can divide into 2 categories. One is the killed vaccine, another is the live vaccine group. So killed vaccine group, including the DTP, hepatitis A, hepatitis B. So these vaccines we can definitely give. There is no two way about it. Especially pneumococcal vaccine, Hib vaccine, you should give to your patient because they are, as I told, they are very prone for all these infections, much more than us. So definitely all the killed vaccine has to be given. Of course, the immunity which will be generated by these immunocompromised host is going to be bit low. So the effectiveness may not be as good as in a healthy individual, but still safety aspect, it is completely safe. Effectiveness aspect will be little less than the normal individual. Coming to the live vaccine, as Girish sir told, we have to think about the CD4 cell count. If the CD4 count is more than 200, then even live vaccines you can give, including the yellow fever vaccine, the MMR vaccine, the varicella vaccine. So it is okay if the patient is, if the CD4 count is more than 200, then they are highly likely to mount a immune response, and it is highly likely to be safe. So you are justified in giving the live vaccines after discussing the pros and cons with the patient. You can almost guarantee the safety. But when the CD4 count becomes less than 200, then the safety aspect is kind of compromised. It may be more of a theoretical than a practical issue, but still, since we are not sure who is going to get a severe infection using these live vaccines, better to avoid. And you can give the as soon as you know that the CD4 count is low, start on ART, and once it is more than 200, you can add. So I would recommend delaying the administration of the live vaccines for immunocompromised hosts. And sometimes there are seasonal vaccines like influenza vaccine. In these kind of vaccines, there are intranasal shots, which is mainly mucosal shots, which is by live vaccine, and there is intramuscular shots, which is killed vaccine. So definitely in these kind of vaccines, you always prefer the intramuscular shot, that is the killed vaccine. So, and regarding COVID vaccination, definitely you need to give COVID vaccination irrespective of the CD4 count. You can give mRNA vaccine, Pfizer vaccine. So in the CDC, they have recently updated that after 2 doses, because they are not mounting enough immunity, after 28 days, a third dose also has to be given. So that is the recent guideline on COVID vaccination.
Okay. Now to the audience, please feel free to post in your questions in the chat box. And to answer, sir, there has been some reports of HIV patients harboring the virus for longer, and within the patient, virus mutating and all. Is there anything we can?
Which virus?
The HIV virus. The COVID virus mutating within the HIV patient.
See, as Dr. Deepu has already told, they are immunosuppressed. So the virus clearance will not be that effective when compared to a normal, robust human being mounting a robust immune response. So the likelihood of the patient continuing to shed the virus is very, very high when in case of an immunosuppressed individual getting COVID. So the virus survives in that particular individual system. So that will, it's a vessel where the virus is getting amplified, multiplying, and there are error rates, and then you don't know what else is happening there. So there the chances of getting mutations in the person's body is very likely, and Omicron also they are hypothesizing that it must have come from a immunocompromised. We have a huge HIV population in South Africa. So they must have harbored it for long, and that must have led so many mutations down the line. But it must be transmitting between the HIV population, we never realized. To get 32 mutations all of a sudden is not possible. So they were gathering mutations, and all of a sudden many people came up with the same mutant virus. So there it developed a fitness for transmission. The moment it developed the fitness of transmission, one whole area, most of the strains were this particular Omicron. So it was cooking up in somebody's body, and it came up.
Okay, sir.
Likely. Hypothesis.
Sure, sir. I'll move on to the last question to Girish, sir, before taking the audience question. So one thing which we have seen over the years is the quality of life of patients who have been detected with HIV. Like unlike before, when we see, we can kind of, the HIV patients, once you see itself, you will be able to identify kind of thin emaciated patients. From there to a reasonably healthy life, people are able to lead now. So if you can elaborate on that.
If you search in internet for an HIV patient's photo, you'll see thin, emaciated, ugly-looking person. So that was happening at least 20 years back. Now what happened is there are newer drugs which can reduce the viral load very drastically and improves the immunity of a person.
Okay.
So nowadays, if you look at a person who is having retrovirus infection, we cannot identify whether the person is infected with the virus or not. That much they have changed. It is something like taking drug for diabetes, taking drug for hypertension or heart disease. Okay, they are looking normal person. Once the immunity is more than 500, you are the HIV person is same like another person.
Okay.
Only thing that still they can infect the virus from their body to other person. That's that precaution they have to take. And as a doctor, we have to advise them not to go for sexual encounters without protection, because at that point they can spread the disease.
Okay.
But once we start the drug, what patient has to think is this is a lifelong drug. It's not a complete cure. Complete cure has not reached. We have not made a drug which can produce a complete cure. So the patient has to take every day this drug. They have to note the time every day, same time. They should not miss not even single dose. If they're missing the drug, then there is high chance of resistance. They're continuously taking the drug. And what we have seen is more than 20 years we are following up retrovirus infected patients. They are like a normal person. So 20 years, same drug.
Yeah.
We have not changed.
Okay.
Suppose the patient is changing stopping the drug in between, they go for they develop viral resistance. Then we'll have to go for a higher drug.
Okay.
So every time we'll not get a higher drug.
Okay.
Last 5 years, only 2-3 new drugs have come. Maybe some more new drugs will come. So patient has to be very careful. They have to take drug every day.
Okay.
They should not miss the dose. If any problem occurring, they should inform the doctor as soon as possible.
Okay. Okay, sir. With that, I'll move on to few audio. Yeah, please, sir.
Viral load which is undetectable. A person whose viral load is less than 50. 50 is the lower limit of detection in the system. So anybody with a viral load viral load which is undetectable, he cannot transmit it.
Oh.
So it's zero transmission. So you have to achieve less than 50 viral load.
Okay.
That is what sir said, compliant medicine. If you come very compliant with the medicine, regularly taking, and your viral load is undetectable for 6 months, then this patient will not transmit through sexual intercourse.
Okay.
Blood he may transmit, but through sexual intercourse he may not transmit.
Okay.
So that is zero, achieving level 0 for HIV.
Oh, okay. Okay, sir.
The particular points are told, that is known as U is equal to U, undetectable is equal to untransmissible. It is a campaign, U is equal to U campaign, where the HIV person can have a totally normal life.
Okay, then we'll move on to certain questions. One question is, respected panel, may I know if tenofovir is renal toxic, and should it be replaced with some other drug?
There are 2 preparations available. We'll send you a mail regarding these 2 preparations, because some has got that is not because of the tenofovir as such, that add-on to that combination.
Okay.
So there are replacement for that.
Okay.
It's a renal toxic drug. But if you change the add-on, then we'll send a mail regarding that.
Okay, sir. Karthik Subramanian's question is already answered by Anil, sir. That is, how about the vaccines for HIV? Is there anything in the pipeline? So that is done. Rahul is asking current management of HIV plus MISA. I think the management of MISA would remain independent of the HIV status, right, Deepu?
Multi-system
Yeah.
inflammatory syndrome. Yeah, management of MISA has to be independent of, because the problem is antibody and antibody mediated multi-organ dysfunction. So the treatment is steroid plus IVIG. It has to be managed like any other case.
There's a question about newer drugs among heart, and what is their efficacy. I think you can refer to Grisha's presentation, which
we have already given a talk on recent guidelines on HIV. There are newer drugs, 5 more newer drugs have come approved, including injections, but it is not available in India at present, so there is no point in discussing that drug at present. But however, we'll be sending some data regarding that to you all.
Okay, then Nimmo is asking regarding COVID vaccine efficiency in AIDS patients. I think we've already answered that question. Then dolutegravir, can it be given in pregnancy? Is there any risk of NTD?
At present, it is safe. We can give.
Okay.
Just to give the numbers, so for example, HIV patient as well as solid organ transplant patients, there was a recent article in JAMA in which Pfizer and Moderna vaccine was 95% efficacious, whereas in solid organ transplant immunosuppressed patients, it was only 50% efficacious. So,
okay. Right. Any precautions to be advised for HIV partners apart from protective sexual intercourse practice?
The main thing is sexual intercourse should be protected. And second thing, when we are dealing with the body fluids, we should be very careful. Otherwise, it's like any other
sharing
person.
anything.
Like Sarah's already told, no? Once the this undetectable range, when that go to that range, if the patient is taking correct medication, actually this undetectable will come within 3 weeks of the treatment if the patient is taking regularly. But what happens is many patients may not take it regularly. So we cannot predict that. Patient only can predict that. 3 weeks, if they are taking regularly, the viral load will become undetectable. So the spreading is unlikely from one person to other person. No need to worry about that.
Okay. Side effects, that's already dealt with. How about malignancies in HIV patients? What is the prevalence? What is the most common malignancy in these patients?
So what we have seen in our practice is because all our patients are taking regular medications. What we are seeing only malignancy is lymphoma, non-Hodgkin's lymphoma. This is the only malignancy what we are seeing. But somebody is not taking ART. Kaposi sarcoma is one of the common presentation, but we are not seeing because our patients are taking tablets. We have around 1,000 patients, but all are taking their tablets regularly because they are counseled properly. So they are taking, and we have not seen any skin malignancies, but it is one of the most common thing. We see NHL, that is the most common malignancy we see.
Again, basically the logic is that, like Kaposi sarcoma is by HHV8, and with falling CD4 count, all these virus will get activated, and then that will cause this malignancy. And similarly, HPV, cervical malignancy, and JE.
No, if you search in internet, so many malignancies they will see. But if the patient is taking regular medication, it is like same other patient. But even on patients on taking medication, NHL is coming up.
Okay. So that is may not be really dependent on it.
I don't know really. But we are seeing some patients with NHL.
One more question is regarding HIV regime for patients with liver failure. Is there any modification?
There is no actual modification at present.
Okay.
We can continue the same medicine, but we have to monitor the LFT. Atazanavir has got some complication. It is not actually liver problem. It increases the it can increase the jaundice, but it does not affect the liver. Indirect bilirubin can increase.
Okay.
But otherwise, the same regime can be continued. But maybe they are asking about regime in hepatitis B or like that. So we have to start treatment for hepatitis B or C, whatever it is. But this drug which is given for HIV can act against hepatitis B also. Lamivudine or tenofovir, both will act.
Okay, there is a question about management in children. Anything specific to be kept in mind?
We are not actually treating children in our center, but I think it is same drugs are given.
Okay.
But we need to take a opinion from pediatrician.
Okay. So I think we have reached 1 p.m. and I'll just ask for any closing remarks from anyone. Anything, answer? No.
Closing remark is in the Western countries, I think they are more worried of dying of heart attack, stroke, everything, and they have many times we see patients undergoing heart transplant, lung transplant. So the survivability is very high in developed countries.
Okay.
So they are more worried of dying of lifestyle disease rather than dying of HIV.
Okay.
So that's the state.
So what I have to tell is when we are treating these patients properly with proper medication, they are like any other person.
Okay.
So the stigma about HIV should be removed even from doctors. Even doctors are not ready to treat HIV because they have the old stigma.
Yeah.
So nowadays it is not like that. You treat diabetes, you treat hepatitis B, treat some other disease. Same like that, HIV is also another disease which can be treatable.
Yeah.
But at present there is no cure. Diabetes also there is no cure.
Okay.
Hypertension also there is no cure. So
Right.
that we should understand.
Okay. Deepu, anything?
I wanted to tell, but I just forgot.
That's okay. Okay, fine. So I think the key message is regarding the change in perception regarding HIV/AIDS itself. Treat it as any other disease, and with that, with treatment, a person can live a good quality of life. I'm sure today's this CME sessions with the initial lecture, the case presentations, and now this panel discussion would have given good insights regarding the topic to all of you. Thank you all for attending this session, and the questions many of you have been asking, it will be soon posted in our community tab. And within next 24 hours, we have extended the time till midnight of tomorrow. So before that time, you have to fill in that Google form, and those who have cleared the exam, we have kept just 50% as the cutoff. It's, as you asked, it's MCQ based only. So anybody who gets more than 50% of marks in that posters will be receiving a completion certificate. It's, as I told, it's all easy questions based upon whatever we have discussed today. So happy learning, and see you another day. Bye bye.
So HIV,
Wait a minute.